So we're going to talk about the new Cochrane Equity Content Strategy. And we're very happy that Cochrane is planning to promote or encourage equity in all Cochrane Reviews. So the objectives of our session today are to help you understand a bit about what we mean by health equity, to learn about the new Cochrane Equity Content Strategy, and to understand the key ways that you could include equity in your reviews. But before we get started, we just thought we'd like to know a little bit about you who are listening. So could you tell us where you're located? Perfect. Okay. So I don't know if everybody can see that, but 67% Europe and 11% North America, Africa, and Asia, and Australia. Okay. And then the next question we wanted to know is whether you have considered equity in a review at some point. Great. Okay, so 69% said yes and 31% said no. We suspected we probably were catching people who are interested in equity in their reviews or have done it already. Okay, so we are the Campbell and Cochrane Equity Methods group. This slide's just showing you a screenshot of our website. Basically, our goal is to encourage authors of Campbell and Cochrane reviews to think about equity and think about how they might incorporate equity considerations in their review. And we've developed and we share on our website tools that might help you include equity in your reviews. So what we mean by health inequity is that there's a difference in health outcomes that's potentially avoidable and could also be considered unfair. And so we often show this picture. So these terms, equality and equity, are sometimes used interchangeably, but we actually mean something different for them. So equality would mean that everybody gets the same sort of access or the same intervention to get to reach their health outcome or the goal of seeing over the fence. And when we talk about equity, we mean that maybe we give a bit more targeted intervention to somebody who needs a bit more help to get to that health outcome. So that's what we mean there. And to think about some characteristics or factors that can contribute to inequity, we use this acronym PROGRESS. So basically this helps to identify where there could be areas where there's potential disadvantage for a population. We use the term disadvantage, but we know that there are lots of terms that some groups or places would prefer. So things like historically excluded or underrepresented populations. But for the purpose of this webinar today, we'll stick with potentially disadvantaged populations. So these could be things that are related to where somebody lives, so whether they're in a high or a low income country, or whether they're in urban or rural setting, or a slum versus a wealthy neighborhood, something like that. The second progress factor is race, ethnicity, culture, and language. The third is occupation, and that includes whether somebody is out of work or unemployed. The fourth is gender and sex, and then religion, education, socioeconomic status, and social capital. And by social capital, we mean the social networks that people have to help support them. And then, obviously, those 8 characteristics don't capture all the potentially disadvantaged groups. So we have extended progress to Progress Plus. So this captures any additional characteristics like age, but it also includes features of relationships. So somebody who might be disadvantaged because of their relationships to other people. So a child who grows up in a home with smoking parents, for example, or somebody excluded from school. And then it also includes time-dependent relationships. So where someone might not normally be considered disadvantaged, but could be for a short period of time. So somebody's just been released from the hospital, or somebody's just been released from jail, something like that. So why is equity important? So Cochrane Reviews aim to be relevant globally and aim to provide evidence that can help improve decision-making globally. So authors need to think about how their review is applicable to other settings and how their results could be used somewhere else. And then the other issue is that average results, or when we combine data, that could hide some of the differences between population groups. So we might not see what's happening for everybody in the population and whether there's a greater benefit for certain groups or greater harms. So we always recommend that authors plan to extract and analyze the kind of information that could help us think about these differences and who's really benefiting from the intervention. So why equity? The former Director General of the WHO, Margaret Chan, said equity in health matters, and it matters in life and death ways. So we like that because it shows it's really important. And then following along that, the guideline development groups are more interested in equity as well. And as Dario mentioned, Vivian is the lead of the Grade Equity Working Group. And there's a new series of papers about how to consider equity in guideline development. And some of the things that guideline developers would maybe want to know would be these things. So are there groups or settings that could be disadvantaged in relation to the problem or the intervention of interest? Are there reasons that there could be differences in the relative effectiveness of the intervention? Are there differences in baseline conditions across groups or settings that could affect the absolute impact or the importance of the problem? And are there important considerations that would need to be considered for implementing the intervention to ensure that we don't increase inequities and they actually are reduced? And so there's a series of guidance papers about that includes an equity extension of the guideline development checklist, how you might think about rating the certainty of synthesized evidence to consider equity in guidelines, and the evidence to decision process. And there's a new Cochrane Handbook chapter on equity in specific populations. So this provides some more detailed information about how you'd consider equity throughout all the steps of a systematic review, and is still in draft form. So if you have an Archie login, you can actually see it and you can still comment on them, I think, maybe.
I think it's too late to comment on them. I think they're coming out.
Okay, so you can see the draft version.
That's with my hat as a associate scientific editor of the handbook. But yeah, I think the handbook will be out in July in hard copy. But we have been asked to develop training modules related to the Cochrane Equity Content Strategy. So we really would welcome your comments on, this presentation and on the chapter, because that can inform the implementation of this. Yeah.
Okay, so to develop the Cochrane Equity Content Strategy, we tried to keep it simple and come up with 4 key considerations that all Cochrane reviews would be able to include. So these are the 4 key issues. So the first is that all Cochrane authors could consider different baseline risks for the outcome of interest, differential effectiveness of the intervention, think about different outcomes and how they could have different importance for different groups in the population, and think about implications for equity. So we're going to go through each of them and give an example, and then we'll talk about some more equity-focused things if you were doing an equity-focused review once we've covered these 4 key issues. So by different baseline risk, we mean that some groups in a population could have a higher baseline risk of a condition, and so they could actually have greater absolute effects from an intervention. But at the same time, a group with a higher baseline risk of adverse events could also have a greater risk of absolute harms from the intervention. And so if you were doing a Cochrane review, how this might change what you do, we think it would just mean you could provide in the background section a paragraph about where you would discuss differences in baseline risk. It could also mean other things like a modified summary of findings table, but we'll come back to those later. So we have an example. There's a Cochrane review about vitamin A supplementation. So vitamin A deficiency is more common in low and middle income countries, and it can impair body functions. So in 2011, the WHO guidelines recommended that vitamin A supplementation is provided in areas where there's vitamin A deficiency, and that was based on a Cochrane review that showed a relative risk for all-cause mortality of 0.76. So in this review, the authors found that the baseline risk of all-cause mortality was 0 in low-risk populations, but 90 for 1,000 in high-risk populations where there was vitamin A deficiency. So the absolute effect in terms of the numbers of deaths that could be prevented with vitamin A were 0 where there was low risk, but 22 for high-risk populations. So the differences in baseline risks were really important. The next equity consideration, the key equity consideration, is about differential effectiveness. So, so this would mean things that could change the effectiveness of the intervention based on the population subgroups. So things like literacy issues or adherence or lots of other reasons for differences in effectiveness. And so for Cochrane Reviews, this could mean you would explore different subgroup analyses or meta-regressions. And if you were writing your review, it would just mean thinking about these when you're writing the section on subgroup analyses, but maybe thinking about how the population characteristics could also be important. And of course, we would recommend that you do this a priori before you conduct any subgroup analyses. And we have an example here. So there's a carotid endarterectomy review. And so they did a subgroup by sex. And so what they found was that for participants with 50 to 99% stenosis, the number needed to treat to prevent one stroke was 9 for men and 36 for women. And so while the benefits for women with 70 to 99% stenosis were very clear, there was actually no evidence of benefit for women with 50 to 69% stenosis, and there was actually more harms from surgery. So I think for those women, other characteristics or other factors would need to be considered before recommending this treatment. And another example from a review on food supplementation in preschool children looked at subgroups based on baseline characteristics or where people are living, and found that children who were more undernourished at baseline actually gained more skin fold thickness than controls. And also, supplementary feeding was more effective for children in moderate socioeconomic status areas than for children living in slums. And then just again, a caution about subgroups is there's a lot of reasons that people don't believe in them. So you have to you should look at this paper by Sun and colleagues that has 11 criteria for assessing the credibility of subgroups, so that you would think about things like whether the direction of the subgroup has been specified, whether the subgroup effect is independent, and if the interaction is consistent across studies. So the third key equity consideration is about outcomes. So outcomes could have different importance for different groups of the population, and some outcomes would be more important to some groups and less important to others. So for example, return to work is important for some groups, or satisfaction. So we would recommend that authors consider the relative importance of outcomes based on input from a variety of stakeholders, including those that would represent disadvantaged groups. So basically, anybody who could be involved in or potentially affected by the intervention, you'd want to get some feedback on what would be the outcomes of importance. So for example, there's a review on workplace interventions to prevent work disability. So employment rates for people with disabilities are 40% below the overall level. So and returning to work is considered a really important outcome. So this review found that it's important to involve key stakeholders in the return to work process, and it's been shown that return to work interventions that involved workplace adaptations and stakeholder involvement were more important than things like exercise, workplace linked exercise. So the last key equity consideration is about discussing implications for equity. So by this we mean a few things, but one would be to think about the applicability of the findings to other settings. So thinking about the context in which the studies were conducted and how that might be related to other settings where the intervention would be important or the outcomes are of interest. And then the other thing would be to think about the burden of the intervention for the patient and the provider. So things like inconvenience, cost, and time that could impact whether the intervention gets implemented as expected or as intended. So for example, directly observed therapy for tuberculosis is a pretty famous intervention for TB. So basically, TB treatment can take up to 6 months, or it should take at minimum 6 months. And in directly observed therapy, the patient gets observed taking every dose of their medication, so daily or weekly, and that gets recorded for the health system. So a Cochrane review from 2015 assessed self-administered TB therapy versus DOT, or DOT at home versus DOT at the health facility, or DOT administered by a family member versus DOT administered by a community health worker. And overall, the review authors found that it didn't actually provide a solution to poor adherence for TB. And it's a pretty famous, I guess, intervention, and it's quite resource intense. But the findings of this review found that you might want to have some other options for policymakers so that they could increase adherence. And another review by Simon Lewin looks at lay health workers, and this example gets at the other issue with describing implications for equity. So this one talks more about the context of the review and its applicability. So they found that they had about a third of their studies conducted in LMICs, or in low-income groups from high-income countries. So they felt that the results of those studies could potentially be extrapolated to other settings, and they could be effective in low-income groups and contribute to reducing health inequities. But the degree to which the findings from the studies in high-income settings could be generalized was unclear, especially for two subgroups. So lay health workers providing support to mothers of sick children, or lay health workers to prevent child abuse. They were less sure about those interventions since both the studies, or all the studies, were conducted in the United States. So the key equity considerations to review them are the greater baseline risk for outcomes of interest, looking at the differential effectiveness, outcomes, and discussing the implications for equity. So we wanted to ask you if any of these three, or which of these three, are relevant to your work, and you should be able to choose more than one option. Okay, so about half said the first option, greater baseline risk, over 81% for differential effectiveness, 63% for outcomes, and 75%. So that's good. They're all important for your work.